Welcome to another episode of the the Dynamic Chiropractic podcast. I messed that up already. Here we go. I am joined by Dr. Robert Trager, all the way across the pond. He has dedicated his time out, part of his day, to join us. So everyone who's listening, please sit back, relax, grab a pen and paper, and be ready to learn something new. So, Dr. Rob, thank you for joining us today.
Thank you so much, Jack. I'm really honored to be here.
Thank you. So, Rob, everyone has their own chiropractic story. Would you do us the pleasure of telling us yours?
Well, when I was in high school, I was a teenager. I was in a minor rear ender car accident and I had a neck injury. Nothing too serious, but that's what first brought me to the chiropractor. And I realized how beneficial it was getting some hands-on treatment. And it just accelerated my recovery. And from then on out, I was interested in this. And then later on in college, I became interested in research as well. And now I'm blending the two together, doing a little bit of both.
Awesome. I love that. What led you to go see a chiropractor after your accident and sort of not go down to see, I guess, a medical doctor?
Well, the funny thing is that I actually didn't see the chiropractor right away, and I struggled with a stiff neck, and I wasn't able to really turn my head for several weeks. And I was running track at the time, and it was slowing me down quite a bit in my different events. So when I finally did go, it was because my mother had recommended it. And my teammate on my track team was his dad was actually the chiropractor. So
Oh,
it all kind of worked out.
yeah. Oh, I love that. That's amazing. And just while we're on the subject of track, I suppose, did you, even after you had your neck, I guess, let's say, adjusted and fixed, sort of those who are listening through audio, floating quotation marks, did you continue with chiropractic care, and did you see a difference within your performance on the track?
Really, it was just sporadic as needed. I didn't go very much. I think I may not have gone back to the chiropractor until several years later. And so it was something that I didn't really do for performance. It was more just that's what I knew of at the time. It was something more for pain, as far as I understood, or limitation. So yeah, I just kind of continued about my way. I
Awesome.
probably should have gone back a little more, but no, it worked out well.
Yeah, that's good to know. I love that. Well, of course, it worked out well because you're now a chiropractor, so that's awesome. So with sort of continuing on in terms of the education, because I can imagine the education is a lot different in the US versus the UK. Where did you study and what was your experience like?
Well, I went to undergraduate at Northeastern University in Boston, studied biology, got all my prerequisites for chiropractic school, and then I went to Logan in St. Louis, Missouri, and that was over 3 years of studying. And then we take our board exams throughout and at the end as well. And I felt very prepared. I mean, it's hard to compare and contrast to the different programs around the world. It's something I'm not as familiar with, but I felt like I had a solid education and preparation.
Awesome. That's cool. And what was the journey after, sort of like when you graduated? What was your journey after that? Because obviously a lot of people go into obviously just straight into a clinic. Obviously, I know yourself now. You're is it that you work in a hospital alongside within I guess you could say acute or even
Yeah, the setting I'm in now, it's an integrative academic healthcare organization. It's very large. I mean, there are over 30,000 employees, I believe, and there's
well,
several different facilities. And one of the clinics I'm in now is it's maybe a little more traditional sort of private practice setting with chiropractic in a community in an outpatient office, and there's primary care and there are other things in the building. But then the other office I'm at is very different from most chiropractic facilities. It's actually connected to a community hospital, and we're upstairs from pain management, and we see a lot of really complex patients with high comorbidities, and we see people that are in wheelchairs and have had spinal surgeries and have had really bad injuries, and they're taking a lot of medications and having procedures done, and maybe they're pre-surgery or post-surgery. So I see a little bit of everything. And I didn't start out like this. I mean, when I came out of school, I wanted to be in an integrative setting. And I started in a smaller integrative practice, which was chiropractic, physical therapy, and there was one medical provider who was a physiatrist or physical medicine and rehabilitation specialist. And that provider was doing a lot of trigger point injections and some regenerative medicine as well. And I really liked that pairing and being able to collaborate with the physical therapist and the medical provider. And I feel like it helped get my patients the right outcomes that I was looking for. And along the way, I decided that I wanted to go further in that direction and have more access to different medical specialists that I could collaborate with. And also, I was getting more and more interested in research. And so I started doing what I could do. When you're in private practice and you don't have all the training, you don't have all the resources and funding, you don't have what we call an IRB, institutional review board. So I did what I was able to do, which was write sort of narrative reviews and book chapters, and started writing case reports as well. And then I started sending those to different people and sort of asking around. And then eventually I got this opportunity to work in the hospital setting. And that furthered my research career as well and opened a lot of doorways for me.
Amazing. I love that. It's just working within sort of like a hospital basis is very rare. It's what you wouldn't see here in the UK. I mean, predominantly, I can imagine it's the same or very similar in the US, but obviously, predominantly over here, chiropractic care is more private setting, so it's very rare you would ever see a chiropractor work within the hospital or hospital basis. How do you find? Obviously, like you said, you see a lot more people with comorbidities within the hospital versus in the clinic that you are outside of that. How do you find the difference between working within the two, like in terms of, can you operate the same way as you do in your other clinic versus in the hospital?
Yeah, I mean, the first 7 years or so of my practice was in like a more traditional setting for chiropractic there were younger patients, more athletes, more sports injuries, and just overall people were healthier. And I think now I just have to you always have to be careful. You always have to look out for what we call red flags and people with osteoporosis, or maybe yellow flags, or people that have heightened pain sensitivity, or complex regional pain syndrome. You bump into someone's leg and, they're flying off the table. So you just have to be like that almost with every single patient, because you don't want to hurt people and you don't want to, irritate people's complaints and things like that. And you want to be respectful. And then the other thing too is, I think, having different doctors around, people that are referring me patients, the pain management, physiatry, surgeons. I think I've always done my best for patients and really thought critically and done good documentation, but you really have to do that in the hospital setting. You are copying your notes to different providers, and then there's a lot of communication back and forth, and it sort of gives you this accountability that you have to work in this setting. And I feel like there's a little pressure and there's a little responsibility as well. Because I feel like you said, there's a small percentage. Less than 5% of chiropractors are in this sort of setting at most. And so we're almost like an ambassador to what the profession is doing. And a lot of the providers I work with, their only contact with our profession is through myself or my colleagues. So they might not have any basis for what chiropractic is, unless, we're telling it to them. So we try to do our best to represent the profession in a positive way.
Great. Well, it sounds like you're doing a great job. So
Thank you.
keep it up. So how many other chiropractors do you work with within the hospital setting?
We have about 7 right now, and we've slowly grown over the past 5 years. We also have acupuncturists, massage therapists, integrative medicine providers, and integrative oncologists and pediatrician in our immediate department, which is sort of a standalone from the main hospital. Like you have every medical department, and then you have our integrative, or we call it whole health department.
Awesome. So obviously going back to the research part of all this, I know briefly when we were talking, you presented a discectomy study at the ICIMH in Chicago. Can you tell us a little bit more about that?
Yeah, thank you.
Awesome.
So this presentation was based on a study that we did. It was published in BMJ Open in December, and it's all based on surgery for the lower back. And basically, chiropractors treat low back pain. That's the #1 condition that we see. And I thought it was really important that we look at whether or not our patients are more or less likely to undergo surgery. And no one had ever really looked at that. I mean, people have looked at that on a very broad scale, but I wanted to look at discectomy or lumbar disc surgery, which is really important, I think, outcome. And so what we did is we looked at this national database in the United States with over 100 million patients.
Wow.
Yeah, so it's a really nice data set. And we included patients that were young to middle-aged adults, 18 to 49, because those are the patients that are at risk to get disc herniation and at risk to get disc herniation and need surgery. And so we had what we call an active control new user design, and we compared 2 cohorts. We had a chiropractic cohort, patients that saw the chiropractor, received spinal manipulation, and patients that had any type of other medical care. And we used this statistical technique called propensity matching to control for confounding variables like age and sex and body mass index and medications, all those things. Because people worry that chiropractors only see mild cases of low back pain. I mean, that's really not true. But we tried to account for that as best as we could by controlling for all these different confounding variables. And so that way that the 2 cohorts, the 2 groups were very similar. And so we did that. And then we looked for 2 years to see what percentage of the patients needed surgery for their disc herniation or sciatic pain. And it was a low percentage in both cohorts, but it was smaller in the chiropractic cohort. So it was like less than 2% versus like 2.4%, something like that. And the odds ratio at the end was 0.77.
Wow.
So the less than 1 odds ratio means that the odds is less likely, the event is less likely to occur in that cohort. So the chiropractic cohort required less surgery for disc herniation. I mean, over 2 years. So it's a really long follow-up. And we had some positive feedback on this. I mean, most people are thinking it's great. Other people said maybe you should try 3 years outcome. And I don't really know if that would change a whole lot. I mean, 2 years is pretty long, and most of the surgeries for disc herniations will happen in the first year. So we already sort of went above and beyond. I mean, I'd like to follow it up, but I think it was a nice starting point, and no one's really ever looked at that before.
So that's a huge study. So well done on plowing through that. That's awesome. I'm glad you got the positive feedback from it as well, because that's always really important to get, especially when you spent so long on a study such as, I mean, 2 years is already a long period of time. So
Yeah.
well done. That's really
Thank
cool.
you. Thank you. Yeah, we did. We spent, I want to say probably 1.5 years on the study, but I should mention that it was all retrospective. So that was the good news, is once we were done with the IRB process and designing the study and putting together the protocol and getting it registered and all the groundwork to get it ready, actually getting the data, I mean, getting the results did not take very long. It only took maybe a month or so, because we're actually looking at data that's already existing. It's just routinely collected data, and it's a low cost, very feasible study. It doesn't require like enrolling patients and then following them like you would in a trial. So it's a very quick study, but at the same time, it would be extremely hard to do this study with live patients, like following them for 2 years. It would be incredibly costly. So that's why we did everything sort of retrospectively.
Yeah, it makes absolute sense. Yeah, awesome. The other study that I wanted to talk about, the one that you co-authored, the one in the Nature scientific reports, the one on the patient, so post-treatment or post-surgery lower back surgery. How
Yeah,
say
so the Nature scientific reports, one was the incidence of serious or severe adverse events among patients receiving spinal manipulation from a chiropractor. And that is actually one of the largest studies on adverse events related to chiropractic spinal manipulation. We had
wow.
over 50,000 patients and we had almost 1 million sessions of spinal manipulation. And so it's really interesting group of clinics that we worked with in Hong Kong. There's about 30 clinics over there, all connected, and they're integrated as well. So they have every medical specialty. They have radiology clinics, they have lab testing, and they have all their records are connected. They also have questionnaires that they send people through text message, and they have phone calls, they have customer service department, and they have all these different things. So it was a great format to study adverse events. I think anytime you do a study like this, you need a really good data set to work with. And this was really strong for us. And having all this data was nice. We were able to look into all these different avenues and different data sources, if you want to call it that, because any one format of getting adverse events is oftentimes inadequate. I mean, you have to survey the patient and get phone calls and use the medical records and use all these different things to try to corroborate them. And then having the radiology information was helpful too, because there were a few cases where we really relied on that to determine what was going on. And so we actually had an integrative authorship team on this, and we partnered up with a couple authors that were not chiropractors on purpose, because they had some medical background as well, but we got together and we actually graded every adverse event. We had a whole spreadsheet of all these adverse events with a description of everything that happened with the patient, their age and sex and everything else. And so we went through, and based on this rubric that's come out that we did not make, but we graded everything on how severe it was. And that I think was really cool too, because I don't think anyone has really done that with chiropractic spinal manipulation, and it enabled us to have a really sort of valid method of saying how severe the adverse events were. And we, at the end, we found 2 that were fractures of the spine or ribs. Actually, I want to check. I'm actually blanking on this. But it was women that were over age 60 with osteoporosis, and they were fractures. And so basically, we didn't find anything like strokes or Cauda syndrome or anything like that. And it may have just been chance. I mean, those things are supposedly very rare anyways, so it's just possible we missed it. But either way, I mean, the incidence was very low of these severe adverse events. So that was reassuring. And we're hoping to see different studies come out like this. I mean, I am actually planning a follow-up right now with the same population I did in the United States, where we're looking at a different outcome. And so I think this safety sort of research is really important. I mean, if there's something going on there, I think we need to own it and sort of figure out how to be safer. But so far, it seems that a lot of these studies are suggesting what we're doing as chiropractors is quite safe. And if anything, a lot of these adverse events might occur with missing certain things on history or exam. I think that may be more important than the treatment itself.
Absolutely. Wow. And with the only 2 adverse events that you had were the fractures.
Yeah, well, there were a lot of other milder adverse events. Those sorts of things are transient and relatively common, and we weren't as worried about those. I mean, the study was geared to identify the more serious ones. So
And
that's a good question.
sorry. Yeah.
No, you're
So,
good.
what were the more serious adverse events you were looking out for?
Well, we were looking really at anything. I mean, we were looking to see if there was stroke or caudate equina syndrome or anything like that. Anything that required a patient to be hospitalized or was life-threatening or resulted in death, basically. And so it was very broad. It could be anything at all. So yeah, and that's just what we found. It wasn't like we were looking just for fractures. I mean, we were looking for anything. So that's a good clarification.
Yeah, absolutely. I don't know if you had this throughout sort of your studying background while you're at chiropractic school, but especially for myself and the cohort that I was in, and I've had the same conversation with other chiropractors as well, that there tends to be a lot of sort of scarcity or a lot of fear around sort of like cervical based adjustments, predominantly through diversified or cavitation, essentially. And it's funny, so I was looking, I was talking with Dr. I don't know if you heard of Jeff Langmaid. Um, he does a lot of sort of reviews of chiropractic work, and he done one based off of cervical incidents, and it's the rate of it actually happening was like, I don't know, I can't quote on the exact sort of
Low,
rate
yeah.
of incidents, but it was like 0.000, just continuous 0.1% in all instances. So I think the fact that you've ruled out so many different, I know obviously this was only in, I'm guessing this was just in the Hong Kong um cohort, obviously people receiving
Right.
chiropractic, but the fact that the level of incidence was just so low is it should give a lot more people more, or a lot more chiropractors as well as the public, more faith in what we do is actually safe, because um, there have been reports more so through the paper. I don't know about in the US, but here in the UK there've been a couple of reports where unfortunately people have had extreme adverse effects through cervical adjusting.
Right. Yeah, I think we need to look into that more. I mean, right now we actually have a systematic review protocol in place for studying vertebral artery dissections in patients that are presenting to chiropractors. And there's been a number of papers or case reports describing patients that have presented to a chiropractor having a stroke in process
Wow.
or vertebral artery dissection. And so we'd like to study what those features are and how to better recognize that.
Yeah. How would you yeah, um, how would you go about um, where would you begin with a study like that? I guess do you have to reach out to multiple clinics? uh, yes, they would then have to dig out some sort of case study, or
Yeah, there are a lot of different ways. I mean, one of the approaches that you've seen, like Dr. Cassidy and Kosloff, and some of these larger epidemiologic studies that have been conducted, where they take a gigantic population with millions of patients and they control for patients that have either seen a chiropractor or seen a primary care provider, and whether or not they had a stroke or dissection, and try to figure out if there's an increased risk with chiropractic versus just an ordinary doctor's evaluation. And so far, they haven't found any increase in association. And Dr. James Whedon did a couple of studies like that as well. So there's a number of studies that have taken a broader epidemiologic view of that. And then you have other studies that are smaller, looking at case reports and case series that show individual patients. And those are tough because usually there's a lot of data that's missing. It's just a sort of temporal association, the timing. The patient saw the chiropractor and then they had this vascular adverse event. It's really unclear what the chiropractor did, and all those different things and different variables are a lot of times missing. And so I think we need to think about how to study this better.
absolutely, yeah.
Sorry about that. So
No, don't worry. Go for it.
the approach we're taking is a systematic review of already published data. So it's all out there already. We're just summarizing it.
Yeah. In terms of research, especially for the future of chiropractic, what do you feel is the research that needs to be produced going ahead? What more do we need to look in for?
I would love to see more data on safety, even though it's already been done. I think we need to see more of that. I would like to see more studies on headaches, migraines, special populations, people like elderly patients, pregnant women, these different treatment outcomes. I mean, there's a lot that's not been explored. I mean, when you look at all the research on chiropractic, it's like low back pain is the biggest chunk. And all these other conditions that we treat have not been studied very much.
That'd be interesting to definitely look into. Is that I mean, once you've finished the current research that you're doing now, what would be the next step for yourself?
Well, there's a lot that's going on. I mean, we're working on different studies to look at different medications that are chiropractors, patients more or less likely to take this or that medication. We are following up the discectomy study with another study with slightly different design. We're doing more studies on patients that have had previous spine surgery, what kind of treatment they're getting. We just had a patient paper accepted on that topic, so expect to see that very soon. All different things. I mean, it just goes on and on. I feel like there's no end in sight. I mean, and the other big one we're doing a study on cost. So what is the cost implication of having a chiropractor? And this is a study that's really awesome. So this is another advantage of working in a hospital setting. So our hospital has its own insurance network. It has an insurance network of 500,000 plus people.
Wow.
And a lot of those people see a chiropractor. And so we can see all that data and we can look at cost. And that's what we're doing.
Amazing. And obviously, I understand it's something that you're just currently looking into at the moment, but just off the top of your head, have you noticed any big difference between people who see a chiropractor versus sort of how much money they would spend, etc.?
Well, there's not a lot of research on the cost implications of chiropractic at the moment. There's a handful of studies, and I think so far it's looking somewhat positive, but it's really tough to say, and it may depend on the population and the geography, insurance types, and all of that. But our setting is unique, and every setting is unique. Every country, I'm sure, every healthcare system, as I'm sure where you are, is slightly different setup from where I am. And so I think we need to look at all those different places individually, because the results might not apply from one to the next. And we're trying to do that here. And basically, if we find that there's a positive impact of having a chiropractor embedded in the healthcare system, I mean, with respect to costs, then that would, I think, remove one extra barrier, and it may actually help people get more access to our services.
In the future, do you see that chiropractic will become a lot more prevalent within hospital-based environments? So obviously, as you said, since you've been working there, your team has grown. Do you see that continue to grow in the future?
Yeah, I really do, because I think it's easier to provide care here to benefit the patient as a chiropractor, and there's less things that get lost in translation. I can see people's records. It just facilitates what I'm doing. Yeah. And I think providers can sense that as well. And even providers that do work with outside chiropractors, I think they think it's easier to do things in-house. And just having the email, having the MRIs and everything we have access to, it streamlines things. And I think when people get a hold of that and realize that, I think it will grow.
Nice. That's good to know. I don't know if it's something that will happen over here in the UK just yet, but I mean, obviously if we see that as making such a positive impact over in the US, and hopefully it will do the same over here as well. But I guess we can only wait and see, to be honest. So
Right.
one of the other questions I wanted to ask as well is obviously while we've got a little bit of time, you said you worked on a book as well.
That's right. Yeah, I
Can you
spent
talk to
like
us a little about
yeah, I spent several years writing a book on sciatic pain just because of my interest in the condition and how it's diagnosed and treated. I mean, sciatic pain is sort of a layperson's term, but I use it in the clinic as well. I mean, it's a very broad term. It's like headache, right? And then when you break down headache, you have tension headaches and migraines and all these different subtypes. Well, sciatic pain is like that too. I mean, the most common trigger is the disc herniation. You have radiculopathy. You also have stenosis, you have spondylolisthesis, and you have all these rare things like tumors and hematomas and all these different things. And we've published case reports on endometriosis causing this. And I mean, there's so many different things with sciatic. I think it's great for chiropractors to be able to own this and to study all the different differential diagnoses and things and conservative treatments that you can do. I mean, I just think it's a fun topic, and I had a good time writing it, and it really helped support and promote me in my career and get me to the next step of doing research. And so anyone that's interested in checking it out, a lot of the chapters are actually free. I think most of the book is free. It's on my Researchgate page. So we can put the link up there for that, because my goal is not to like profit. I mean, if you want to buy it, great. But I think now I've switched gears and my focus is more clinical care, research, education, stuff like that. So thank you.
Yeah, if you could send me the links to any of that, I'll be more than happy to post it along with the podcast so people have access to it. That'd be really cool. So thank you.
Absolutely. Yeah.
Yeah, I appreciate that. In terms of obviously on the line of research for students or student chiropractors, those that want to go down sort of the research route, I guess it would be a little bit different over in the US versus the UK, but what would you recommend that they do in order to get into the research side of things?
It's tricky because there's not a clear-cut path for a lot of individuals that are interested in being a chiropractor and doing research. And you may have to be creative. I mean, some people will do a master's degree, some people will enroll in different programs. But I think finding a mentor, finding the right resources, and just working and doing what you can do. I think thinking about ethics is probably the most important thing, and trying to stay within the confines of what you're able to do. I mean, because it's great to be motivated and all of that, but if you don't have the right resources and credentials and sort of all that kind of stuff, you really are limited as to what you can do. But I think doing what I did and following those steps, writing just narrative reviews and also case reports, and then also just reaching out to people like myself and volunteering and seeing what you can do to help. All those things are great. And then you can always get more education. You can always get more training as well.
Definitely. That's great. Thank you. Just while we have a little bit of time left, because I don't want it to kick us out before we finish up properly. But if anyone wants to get in contact with you, if they want to follow you on, if you have social media, etc., where is the best place to get hold of you?
Well, my email is great, robert.trager, that's Trager at uhhospitals.org. LinkedIn, Researchgate, all those different things. I mean, I'm happy when people reach out, and I love to talk to people. They have ideas or questions about research or what it's like to be in a hospital. So yeah, don't hesitate.
Awesome. I really appreciate it. Again, I'll put that in the description of the podcast. So I appreciate that. Thank you. Cool. Yeah, I just want to wrap that up just before it kicks us out, because Zoom tends to have likes to kick us out a little bit early. So Dr. Rob, I really appreciate your time today. Thank you so much for given us so much insight into research, into chiropractic. I've got no doubt it will give people, especially chiropractors, a lot more faith and also a lot more certainty in what they do. And by doing that, if they are able to improve that certainty in themselves, then they can put a lot more confidence in their patients as well. So thank you. I really
Thank you.
appreciate
I
it.
really appreciate you having me on and your insights and your well thought out questions.
Well, thank you. It's an absolute pleasure having you on. So, Dr. Rob, I'll let you carry on. Enjoy the rest of your day. What's the time over in the States at the moment?
It's 3 in the afternoon.
3 in the afternoon. Okay, fair play. Well, I hope you enjoy the rest of your day.
You as well.
And I'll let you know when this is all ready to go, and I can send you the link and everything.
Thank you so much.
Cool. No worries. Dr. Rob, enjoy the rest of your day.
You too. We'll see
No
you.
worries. Cool. Take care, man.
You too.
Bye.